And our next presentation is presented by Dr. Lorraine Drapek. She is the nurse practitioner at the Department of Radio Oncology at the Massachusetts General Hospital in Boston, Massachusetts. Dr. Drapek, she has practiced for oncology nursing more than 20 years. Primary of her work is focusing on curative and pediatric care, symptom management, patients receiving care on clinical trial, and survivorship. Also, she is the member of the Nursing Advisory Board of the Cholangiocarcinoma Foundation. Okay, Dr. Drapek, please.
Thank you very much. It's an honor to have this opportunity to present for all of you. And as you can see, we're going to talk about radiation today. I'm going to start really quickly going through the role of radiation. Previously unclear, but we have some evidence. We have some cancer trials now. So radiation is used in the adjuvant setting following surgery and chemotherapy. It's also used pre-transplantation as well. So when you look at the role of radiation therapy, a trial by Hong in 2016 with Proton Therapy. This was HCC and cholangiocarcinoma. It showed a 94% local control at the site for patients with inoperable cholangiocarcinoma. Ben Joseph in 2015 did a study of extrahepatic and gallbladder cancer and with 4 cycles of gem cape and concurrent cape with radiation with a 65% overall survival. In the US, the incidence of cholangiocarcinoma is so low that we do combination trials only in order to accrue. If you were in the session this morning, you saw that one trial did close because it did not accrue. So I just wanted to show you, this is a proton therapy plan, and the benefit of protons is that they are charged particles, they can be controlled. And in this situation, you can see there's an effect, it's a nice margin effect. There's something called the Bragg peak in proton therapy where they can charge those protons up, they can come to a peak, and then they drop right off. In this particular situation, it's very advantageous because we are not far from the stomach, and this would decrease any toxicity to the stomach as well. We're going to go into stereotactic body radiosurgery, which we also do, but this is a study by Jung and Mataheven in 2015. It's a multi-center study of inoperable patients. They had a median overall survival of 11 months. So the advantages of SBRT, the biggest advantage is it minimizes liver dysfunction, radiation-induced liver disease. It spares normal tissue, and you can really deliver precise radiation to the targets. This is an SBRT plan. And there is some, with photons, you always have some exit dose, but this is far less. And as you can see, there's a lot more contour. There's a minimal, if you look at the colors, the tumor dose gets the most over here, and the other lines around here show the other percentages, and there is very little toxicity from SBRT. It's extremely well tolerated, and we're seeing that more and more. The other thing too is the treatment schedule is far less, often done in 5 treatments. Just wanted to show this article. This is for new developments in radiation oncology, where radiation and dual checkpoint blockades activated non-redundant immune mechanisms in cancer. This was in Nature in 2015, and it really excited the radiation oncology world. So this is an example. This is a trial we have accruing right now in the institution where I'm from with HCC and biliary tract cancers with durvalumab and tremelimumab and RT. And patients start out with cycle 1 of the durvatremi, as we call it, and then in cycle 2, they get durvatremi plus radiation, and then they just keep going after that. And for those of you who haven't experienced or haven't had any exposure to this, These are advanced cancer patients. You want several targets to be able to measure. Only one target is radiated, usually in 3 treatments, 8 gray times 3. So a small dose, but each dose is large. And it's either to a liver, nodal, lung, pulmonary, or soft tissue, again, in advanced cancer, with the thought that when you radiate this one node, that it's going to set off an immune response so that when you look at scans, it's going to systemically affect the disease and you'll see a response in the others, the other nodes. I have no results to share with you. This trial is still accruing, but we're excited about it. Getting to complications of fatigue. So talk a little bit about cancer-related fatigue and radiation. We grade everything, at least in our radiation department, and we use the CTCAE, the common terminology criteria of adverse events. Right now we're still using version 4.3. So to talk about fatigue, it was mentioned by both Sue and Renuka before. It's the #1 effect that I see in patients getting radiation to the liver. They complain about fatigue more than they complain about anything else. Usually grade 1 or grade 2, which is fatigue relieved by rest, or fatigue not relieved by rest, and limiting some ADLs. If they're grade 3, we're going to give them a treatment break because these are people who are not getting out of bed to do the things that they're supposed to do. Also, when I look at evidence, I often look at the Oncology Nursing Society putting evidence into practice as well as literature, and these are some of the recommended. And as Dr. Iyer said, exercise is #1 for likely to be effective. Other interventions, as you can see, are to develop good sleep habits, energy conservation, ginseng, management of concurrent symptoms, very important. If someone's nauseous, they're going to be more fatigued. If they have pain, they're going to be more fatigued. So it's really important to manage those other symptoms. Massage or aromatherapy might help, mindfulness, multiple rehabilitative interventions, physical therapy, occupational therapy, whatever they might need, and psychoeducation. So in looking at acute pain, we often will see some capsular pain in radiation. The other kind of pain that we see is if patients have been previously resected, they can have pain in the scar tissue area. So when we look at pain, it's graded to mild as grade 1. Moderate pain is limiting some instrumental ADL is grade 2. I don't really see grade 3. Most of the time I see grade 1. It's usually over-the-counter interventions. They can use anti-inflammatories pretty much on that, but it's pretty low. So, sorry. When we look at nursing management, again, in the ONS PEP, putting evidence into practice, likely to be effective, gabapentin if they have neuropathic pain. Other interventions, hypnosis, music therapy, and these are all in the anti-inflammatory category. I am not familiar with nefepan or peroxide, but I do use tramadol in my practice. I have sent patients for acupuncture, acupressure, even though effectiveness has not been established because I've found that for some patients it's helpful. Anorexia, which is involuntary loss of appetite. So when you look at anorexia, it's loss of appetite without change in eating habits, so you don't see patients losing weight. And grade 2 is its oral intake is altered, but not enough so that we're seeing weight loss. Pretty much in my practice, grade 1 and grade 2 are what I see. I don't see extreme weight loss, but I also will, I will disclose that from when patients start treatment or before they start treatment, I ask them to go for a consult with the dietitian, a nutrition, just to stay ahead of this as well. When we look at ONS, putting evidence into practice, recommended as oral nutritional interventions. Progestins, we don't really use those anymore. I don't know if you use them in your practice, but they can. MEGAs can affect some tumors, so it sounds like you don't use them much either. Likely to be effective corticosteroids when we have to. but only when we have to, on the corticosteroids. Radiation dermatitis. Skin reactions that are based both on time and dose factors, chemo with radiation, which we are doing more and more often. We can see some enhanced skin reactions, and then immunotherapy can also lead to delayed skin reactions. I'll give you an example. When on the durvalumab trial that I just spoke about, they get the durvalumab on week 2, and sometimes week 6 to 8, they're getting their skin reaction. They have a rash. Right, I can outline the whole radiation treatment field with their rash. So from, some general principles in radiation that were by Rebecca Wong and also in the ONS PEP. Wong did a meta-analysis published back in 2013 on radiation dermatitis, and there were only some general principles that came about from this trial. And one is to have patients wash the field. Washing is number one, preferably with a mild moisturizing soap that is unscented. Secondly, loose, comfortable clothing. We don't want friction to the skin. We want nothing rubbing up against it. She also found that wearing antiperspirant is okay. This is most applicable to the breast patients, but many patients that I run into believe that they are not supposed to wear antiperspirant. And then IMRT, which we use formulations of IMRT all the time. So nursing management of radiation dermatitis. So grade 1 and grade 2 are pretty much what I see in this type of radiation. Mostly grade 1, which is just some skin discoloration. Grade 2 I might see in a woman with who experiences a high amount of liver radiation, so that we see some reaction under the inframammary fold on the right. And sometimes I can see some blistering for that. Not often, but sometimes. So likely to be effective. Again, we're going to talk about the ONS PEP, or topical steroids, and this also was pointed out by Wong in her study. She liked mometasone. Calendula, which is something that we use often in my practice, and sulfadiazine. So other signs and symptoms, again, cholangitis. If the patient has stents, sometimes radiation causes a lot of inflammation, and you can see some cholangitis symptoms. So sometimes there's like sludge that can develop inside the stent. So this is something that to teach the patient that if they develop any fever, if they develop any discomfort, as Charcot's triad, that they need to report those symptoms. Also, as nurses, looking for changes on the labs. If you start to see liver enzyme changes, that can be an early sign, as well as, because you're not always going to see high white count. Sometimes the white count is down too with radiation, particularly lymphocytes. So it's really important to teach symptom management. And then nausea, again, I didn't go over nausea in depth. It's usually very, very mild with radiation. I don't see a lot of nausea, maybe sometimes if the field is close to the stomach, but pre-medication with antiemetics usually takes care of it. Usually don't need more than that. So we ask them to pre-medicate about an hour prior to coming to radiation. And again, always look at your lab values and make sure that you're familiar with the LFTs, total bili, looking for any changes. We do see platelets drop during radiation, so making sure your patients know signs and symptoms of bleeding, platelet precautions, as well as signs and symptoms of infection, because the white count may be low as well. So some conclusions: the use of radiation, it still is controversial, but it's being accepted more and more for biliary tract cancers. And new technologies may allow for some more innovative approaches to radiation. There's a lot of trials going on to evaluate the efficacy of these new strategies, particularly with immunotherapy, which really seems to be promising. And overall, it is well tolerated. by patients with cholangiocarcinoma. So again, future goals, radiation, immunotherapy, combinations, the next stage of development. And I would like to thank Dr. Theodore Hong for allowing some of his slides to be borrowed and presented during this presentation. Thank you very much.